Let's start with, I think we start with Mr. Bilal Khan Saab. He is also our co-chair. I'm Sofia Farooq. I'll be chairing this session. Co-chair is Dr. Bilal and will be moderated by Dr. Majid as soon as he joins us. Dr. Bilal Khan is going to talk about 4-point fixation of intraocular lenses using Gore-Tex suture, the tips and tricks of the technique. So, Dr. Bilal Saab.
Assalamu alaikum. Good morning. I'm going to discuss about 4-point fixation of intraocular lenses. Some of the indications for this technique are aphakia and pseudophakia following complicated cataract surgery with poor capsular support, dislocation of entire IOL capsular bag complex, opacified intraocular lenses, dislocation of natural crystalline lens in conditions like trauma and Marfan syndrome, cases of uveitis, glaucoma, hyphema syndrome, where IOL haptic may be irritating iris and ciliary body. Our options of intraocular lenses in cases of poor capsular support include anterior chamber intraocular lenses, iris fixated lenses, and scleral fixated lenses using both sutured and sutureless options. For sutured scleral fixation lenses using Gore-Tex, some of the available choices are ACREOS and Envista lenses from Bausch & Lomb, as well as Clear and Mini 4 lenses, which are available in Pakistan. Sutureless options using Yamani and modified Yamani techniques are listed here, but they are not topic of our discussion today. Gore-Tex, the suture used for this technique is polytetrafluoroethylene suture of CV8 size, which is approximately same thickness as 7-0 suture of any other material. It's a microporous, non-absorbable monofilament suture of flexible biomaterial known for excellent handling, reduced hole leakage, and minimal irritation in soft tissue approximation. Its main use is in cardiovascular and general surgery procedures. Its use in this technique is off-label. Gore-Tex can be used for true 4-point fixation using ACREOS-style lenses with four eyelets. It can also be used for a pseudo 4-point fixation using Envista-style lenses, which have 2 eyelets at optic-haptic junction. Prior to selecting the patients for this technique, it is imperative that we carefully examine conjunctiva and sclera of the patient. Patients with the tube shunts, multiple previous conjunctival violating procedures such as pterygium excisions, and rheumatological conditions affecting conjunctiva and sclera may not be best candidates. Similarly, patients who had prior multiple vitrectomies as well as scleral buckles may not be ideal. Patients should be clearly explained regarding prolonged healing time, more redness and irritation compared to typical cataract surgery, as well as higher likelihood of needing glasses prescription after the surgery should be explained. Better to avoid in patients with unrealistic visual demands in this day and age of premium multifocal lenses. Surgical technique involves external markings on the cornea 180 degree apart at 3 and 9 o'clock positions using a toric cornea marker. Limited conjunctival peritomy and cautery of underlying sclera is then performed. 425 gauge sclerotomies straddling the corneal marks are placed 3 millimeters from limbus and 4 to 5 millimeters apart using trocar handles or calipers for the measurements. Accurate marking of 3 millimeters from limbus is essential for 2 reasons. Number 1, to avoid tilt decentration and iris chafing, and also to prevent any refractive surprises. 3 millimeter entry simulates the in-bag position of the lens, and IOL calculations can then be used appropriately. Entry of the trocar should be non-beveled, unlike our conventional small gauge sutureless vitrectomy. Standard vitrectomy with removal of capsular bag and its remnants from the anterior segment and any dislocated IOLs or nucleus from the posterior segment is then performed. In this sequence, we are removing a dislocated opacified lens from the posterior chamber, bringing it to an anterior chamber, then bisecting it with a scissor and removing it through a corneal wound using Pacman maneuver. New intraocular lens is correctly oriented outside the eye, and Gore-Tex sutures with its needle cut is divided into 2 pieces and looped through the eyelets of ACREOS or appropriately available lenses. At this stage, some viscoelastic can be injected in the eye, and infusion pressure is lowered to around 15 to reduce the risk of iris prolapse. Corneal incision of approximately 3 millimeter width is made, if not already present as part of prior surgical steps. The handshake technique with 2 flat forceps, usually Alcon max grip forceps, is then used to pass the suture One forceps enters through the trocar, and the other forceps holding the suture enters through the corneal wound, and then the sutures are exchanged between these forceps and externalized through the trocar. All four suture ends can be passed out of their corresponding sclerotomies prior to IOL insertion, keeping stands organized. I usually pass the distal sclerotomy sutures first, and then the proximal sclerotomy suture on one side, and then repeat the same sequence on the other side. Lens is then manually folded with McPherson forceps and introduced through the corneal incision into posterior segment. Once the lens is in posterior segment, you can gently tug on these Gore-Tex sutures at both sides to make sure the lens is properly oriented and there is no tangling of the Gore-Tex suture. Trocars are then carefully removed over Gore-Tex, making sure Gore-Tex is secured when the trocars are being pulled, so there is no inadvertent pulling of the Gore-Tex during this removal of the trocars. Once intraocular lens is inserted, well-centered, and correct suture orientation is verified, Gore-Tex suture can then be tied using a standard 3-1-1 technique. When tying the knot, it is important to make sure that there is no excessive tension on the eyelids of the lens, as well as no decentration of the lens. The knots can then be rotated internally, as we are doing in this picture here, and this can be achieved with a max grip forceps and then trimmed after it is inside the sclerotomy. Alternatively, you can also trim the knot externally and then try to rotate the knot, but there can be a risk of unraveling of the knot if you are trying excessive manipulation. Corneal wound is finally closed with 10-0 nylon or vicryl suture. Sclerotomy sites may be left for self-sealing if there is no leak, or sutured closed with absorbable suture of one's choice. Usually I use 7-0 vicryl. Care must be taken to avoid cutting the Gore-Tex suture while passing the needles for sclerotomy closure. As you can see in this picture, the needle is pretty close to Gore-Tex suture, and if you inadvertently cut the Gore-Tex suture, it will lead to immediate dislocation of the lens and unfortunately a fishing expedition into vitreous cavity. Peritomy should be finally closed, making sure Gore-Tex and all sclerotomies are well covered by conjunctiva and tenon. Few last points to remember. Aqueous is a hydrophilic acrylic lens, and there are case reports of opacification of any hydrophilic lenses with intraocular air, gas, or silicone oil. So it's important to avoid these lenses in the patients who may potentially need future vitreoretinal surgeries. It is better to use Envista hydrophobic lenses in these cases. This is how the eye will look few weeks after the surgery. You can see Gore-Tex under the conjunctiva, and patients should know to inform other eye care professionals regarding the presence of aqueous-styled suture lenses. Very rarely a suture granuloma can form at the site of the buried knot at the sclerotomy site, and any other eye professional trying to remove any tissue from there can inadvertently cut the knot, leading to dislocation of the lens. Thank you very much for your time and attention.
Thanks, Dr. Bilal Khan, for excellent presentation of a newer subject and the new technology in the use of EDOF lenses. Any comments or questions from the next? Thank you. Thank you very much. Now I request Dr. Adnan Abdul Majid. Dr. Adnan Abdul Majid. He had on the same topic. Sir Moin, आपने जाना होगा, आइए. Professor Moin, our great ophthalmic scientist, will have a talk on EDOF, the future cataract refractive surgery. It's the future of cataract and refractive surgery. Moin साहब की ज़बान से सुनिए.
Assalamu alaikum everyone. My talk is going to be EDOF is the future of cataract refractive surgery. So it looks like EDOF is not a fad, it's more like a new baseline, because they are exchanging a bit of near vision along with distance vision, but the main thing which they're doing is relieving the patients of the distortion and the halos which you get in other type of multifocal IOLs. So visual disturbances which typically patients would see in multifocal IOLs would be due to visual disturbances and due to poor vision at distance sometime, and then sometimes they feel that you're selling a very expensive product to them. So there are multiple barriers which you feel in patients with very high-end expensive IOLs, but the EDOF lenses, the good thing is they are slightly cheaper than the other IOLs which you get, the multifocal IOLs, And these are the typical phenomenon which you will get in these patients. And when I started off my multifocal IOLs, the main thing which the patients came in, I cannot drive at night. What have you done to my eye? I could see properly. They're all circles around my eye. It's a lot of glare. I cannot do work. Please take the lens out from my eye. I've seen people getting IOL exchanges because of that. And then there were adaptability problems that you put one multifocal in one eye and then until you put the other eye, the neuroadaptation does not take place. So there are multiple problems which you faced at that time with multifocal IOLs and these other things. So these are basically, you do not get a sort of a point focus, but the focus you have is in a line in EDOF lenses. So there are three basic types. One is a small aperture, and the other is a diffractive, and the third is a refractive lenses. So they've evolved over time. So these are different types. So either you can make the aperture smaller, so you can get a pinhole effect with that, or you can diffract the light and get multiple point of foci, or you can have multiple refractive surfaces on the lens, which will make it sort of adjust for near and make it a line focus. So EDOF lenses, which are pupil, small aperture, they are pupil dependent, and obviously they will have problems when you go in dark and light, so the problems will be there. They're not ideal lenses, but they were a start when they started off. Then came a sort of diffractive lenses. So you have that light scatter over there. When the light scatters, it will produce those halos and grays which you see in these patients. And then you've got these are the typical, the symphony lens. Then you've got the refractive lenses in which the spherical aberration based, or then the newer technology, the latest one is you modify the wavelength which is going through that intraocular lens. So these are EDOF, which, as you can see, there are multiple segments which are refractively different. So they produce different foci. And these are, this is Lucidus, which is advanced refractive design, and then these are non-diffractive lenses, which is X-wave technology, in which you get modification of the wavefront, which you see in these patients. And typically you can see these in multiple products which are available from either Alcon, Rayner, and we see CFI was there as another product, and we'll have live surgery on Elon as well tomorrow. So this is another product which is there by Medicontour as well. So the main aim is that you are stretching that area of focus into a line rather than a point focus, so that whenever the area of focus shifts to near or far, the patient can still see a clear image. The important thing to remember is you always tell the patient that you will still need glasses for near, you need for very small print, you'll need 1.5 addition for this. And you can see patient reported high quality of vision without spectacle at all distances. So you can see the Vivity is the IOL, which is an EDOF lens, and then Acrisoft IQ is the other one in gray. So you can see they perform better for distance and near for both ends. So EDOF is not just a future, but it is likely to be the center of gravity for premium IOL. So that is the reason I think it's time that everybody will going to shift on to EDOF lenses, and these is going to be the future. Although you compromise the clarity, or probably not the clarity, but the contrast sensitivity might be slightly lower in these compared to the other lenses, because you're getting a line focus rather than a sharp point focus. So still, if some people want to have a very sharp focus, fixed focus lenses or monofocal lenses are going to be the future for that as well. Thank you very much.
Thank you, Professor Moeen, for a nice talk. Our well-known, renowned poet, ophthalmologist, Professor Ziaul Mazari, he is entertainer at the same time. His poems related to the science of ophthalmology are always appreciated by everybody. He is talking on safety and post-op results of EDOF IOL implants.
इल्म और तकनीक का मजहर दिखाया आंख में, हमने फोकस साउथ का जादू जगाया आंख में. I am just going to summarize Professor Moeen's presentation. Safety and post-op results of extended depth of focus IOLs. काटकर चीला गुलाफे मोतिया बाहतमाम, देखो कैसे मजहरी ने दिल बनाया आंख में. So depth of field Professor Moeen explained very well. And I summarize this EDOF lenses with another angle. As Professor Moeen mentioned, it's the technology of future, and the focus of the industry is to replace monofocal lenses with monofocal EDOF in due course of time. And what is being done with EDOF, they come with different terminologies, but actually it is reintroduction of spherical abrasion in a refined and controlled manner. You know, with spheric IOLs, we came to aspheric IOLs, and we finished spherical abrasion by introduction of aspheric optics and came to a point focus. But once we lose that spherical abrasion and we get the point focus, we lose the depth of perception. And if we reintroduce spherical abrasion, you will see different lenses and different companies are doing it differently. Like Lucidus produces a spherical button in the middle and dedicates rest of the optic, aspheric optic for vision. And thus, instead of a point focus, it provides a range of vision, increasing the depth of focus. So that shows that the spherical lenses have an inherent beauty. Because of that conoid of Sturm, there is range of clear vision instead of a point focus. And interestingly, I have reviewed and used multiple EDOF lenses. This Lucidus is the only lens yet around the world which is providing EDOF from near to intermediate distance. Vivity by Alcon, EMV by Rayner, Elon by Medicontour, Evolux by Sifi, all of them provide extended depth of focus from intermediate to far distance, which practically is less useful as long as the patient is concerned. We need this range of clear vision more from near to intermediate distance. And this is the only lens by SAVIOL Switzerland with the name of Lucidus, which provides extended depth of focus from near to intermediate distance. And they do it by providing a spherical button in the center and dedicating the rest of the optic for the far vision. We have published 2 papers already, and right now in the resident paper session, another study of Lucidus is being presented, in which 92% patients were 6/6 for far and 85% patients were N6 for near with bilateral implantation. So this is the beauty of this lens. It really challenges the trifocal lenses in terms of dependency on glasses, and it's a quality product. And this is how we inject it. It comes separately. We have to load it in the cartridge, and the haptic design is relatively atypical. So make sure the leading haptic goes into the bag, because the distance between this dual loop haptic is relatively more as compared to other lenses. And this is how you load it in the cartridge like all other lenses. Evolux by Sifi provides EDOF at intermediate distance and comes preloaded, but the incompatibility in our experience we have seen is very high with the injection system. It's a hydrophobic lens and is made of a kind relatively stiff material. And there was a deep transverse arrest in one of my patients, and I had to perform C-section there on the table to reload it and implant it. So the lens is good, but difficult to implant because of its incompatibility, and the hydrostatic force quite often makes it sticky, and it goes inside the eye with open legs, with open haptic. So you need to be careful about that. Otherwise, it's a beautiful lens. And the nozzle is good, goes smoothly through 2.75 millimeter incisions. But opens up, you see, it's opening up with extended haptic. So be careful and move your nozzle back. Otherwise, it can end up in a surprise. Medicontour Elon is another beauty, but as you have seen, may have seen noticed in Professor Moeen's presentation, it has two steps in the center. So where there is a ring, there is dysphotopsia. There is no ring in Lucidus, no ring in Avolux, but it has two steps or rings in the center. So that's why the dysphotopsia is there with Elon, which is not there with Avolux and Lucidus. And this is a live surgery clip from previous Lahore Ophthalmo 2024, in which we implanted Elon live and on the Saturday of last conference. It behaves very well. It resembles famous Rayner design as long as the lens is concerned, and the use of that injector is quite cumbersome. It has a kind of drum and has multiple steps, and I have seen that except Hoya and Alcon hydrophobic lenses, these Elon, Avolux and EZY lenses, it's better to wash them with saline before making them, before injecting viscoelastic over the lens. It makes your life easy and decreases the surprise. So this is a comparison of the different lenses which we have used: Lucidus, Elon, Avolux, Vivity, Alcon, and EMV Rayner, and Isopure by Phys IUL is recently there. A beautiful lens, again providing extended depth of focus at far to intermediate distance. Only Lucidus in this table provides extended depth of focus at near to intermediate. And Avolux we have already discussed. Vivity, I have a very limited experience with it, but the patient I had was not happy because of relatively waxy vision and dysphotopsia at night. And they use wavefront modification, but the bottom line is reintroduction of spherical aberration in a controlled manner is the mechanism of all EDOF lenses. We are very happy with Lucidus outcomes, and over 200 IOLs I have implanted in my experience. So this is their mechanism. The dysphotopsia is almost very rare with Lucidus and common with Elon and Vivity. And it's also not there in case of Avolux, and EMV we need to evaluate yet by Rayner. I have implanted 2 EMV lenses. They behaved well. The EDOF technology appears a safe and economical and a technology of future. It appears to minimize the risk of nighttime photopsia and glare. Studies with bigger sample size and longer follow-up are recommended, and hopefully we have studied Lucidus in detail. 2 papers are already published, one in PJO and one in Saudi Journal of Ophthalmology, and another paper is coming up with the experience of 50 IOLs, and another project we are going to plot the defocus curve of bilateral implantation It's a prospective study, and we are going to compare isopure by BVI and Lucidus by SAVIOL in that study. Thank you very much.
Thank you, Professor Mazari. Would you like to continue with the other presentation? Slow motion phaco, surgical strategies for zonular weakness.
So from EDOF, we come to slow motion phaco, surgical strategies for zonular weakness. So first, for any such challenge, you have to recognize the risk, evaluate carefully, look for phacodonesis, and be ready with the preparations like CTR and hooks, and choose a right IUL like Acrisoft multipiece or a Kova multipiece IUL with specialized haptics designed for sulcus placement as well as sulcus fixation or haptic externalization. The square edged lenses are not good for sulcus placement because of the same kind of UGH syndrome which we used to see with anterior chamber IUL. So minimize turbulence to prevent chamber collapse and vitreous prolapse. To minimize that, you need to reduce the bottle height, decrease the flow rate, and use cold phaco and low vacuum. And you need to have a little patience built in your hands and minds. So the incision, rexes, in all the steps, we have to be careful that we don't aggravate the already present zonular weakness. The early placement and timely placement of 1, 2, 3 or 4 iris hooks can really give you a good round rexes. The iris hook can be placed at any time. You start rexes, you just complete 1/3 and you can place one hook to stabilize the crystalline lens and complete the rexes. And you can use as many as you like. Intraoperatively, again, we need to minimize stress on zonules, judicious use of viscoelastic, and while chopping, we need to use the proper chopping technique and divide it into multiple wedges, and again avoiding any stress on zonules. In irrigation aspiration, tangential stripping of the cortex to avoid zonular stress. CTR timing, the late you implant, the better it is, but never too late. So my preference would be to implant CTR to complete initial steps with hooks till nuclear emulsification. And after removal of nucleus and cortex is the ideal time to implant CTR if needed. But the other surgeons do it otherwise as well. While injecting the IUL, again we need to do it in slow motion under VN and take care that leading and trailing haptic go inside the bag without posing any threat to the already weakened zonules. And if we notice that the subluxation is progressive in nature, don't believe on the intraoperative centration, but do consider haptic tucking or fixation, because the progressive subluxation, the whole CTR IUL bag complex will drop down. So in case of, in that case, you need to fix even if the IUL appears well centered after CTR implantation. We need to be prepared for vitreous loss, and we need to take care of vitreous in a proper manner.
Of slow motion emulsification from managing a cataract case complicated by zonular weakness is going to be explained in this video presentation. Mark the study note Such cases demand careful handling to ensure safety and optimal outcomes. Let's walk through this step by step. Before the procedure, a thorough assessment of the patient is crucial. Whenever stability was detected during preoperative evaluation, to mitigate the risks, we prepared capsular tension veins results for potential use. And the multi-piece axis of IUL along with volume sutures was arranged and haptic taking was kept in mind. Initially, CN and capsular axis was performed. We create a clear polyol in CN. Notice a slow and controlled injection of viscous during the anterior chamber. Then the capsular axis is performed meticulously, avoiding any traction on the zonules, and we aimed it to be centered. The step is critical in maintaining capsular stability and ensuring subsequent CPR placement if required. Hydrosection is performed gently to avoid undue stress on the vacant zonules, followed by placement of an aerosol on the capsule because the capsular hook was not available, and then the slow motion emulsification ensures. During emulsification, the chalk technique is employed, segmenting the nucleus into smaller and manageable pieces. Note how the reduced vacuum and flow rate minimizes the turbulence, protecting the capsular bag. And the second instrument is quite active, and bit by bit, this relatively hard nucleus of a 40 years old plus lady is gently emulsified without precipitating the zonular weakness. And this is the time now to implant the CTR, and the capsular tension ring is being implanted into the capsular bag with bimanual technique, again avoiding any undue stress, and successfully implanted. It stretches the capsular bag beautifully. But at that point, the tendency is to implant the IUL and close the case. But considering the progressive nature of the marginal subluxation, we decided otherwise and decided to tuck the IUL haptics to confer long-term stability. The capsular hook was removed and taking sides were marked by toric marker, 180 degrees apart, 1.5 mm posterior to the limbus. Axis of multi-piece IUL was injected, and trailing haptic was left in the wound, whereas the leading haptic was externalized through the inferiorly created keratomencia. And then the 30 gauge needles enter from the fixation site, and viscocannula is used as a guide to externalize the needle through the inferiorly placed frequency, and the IUL haptic is threaded into the needle and externalized through the fixation site. The heater square is used to convert it into the shape of a bird so that it remains stable. The needle is again entered from the superior fixation site, and it comes from the superiorly placed insignia, again guided by the viscocannula, and the haptic is again threaded into the 30 gauge needle and is externalized and again converted into a bulb with the heated squint lobe. And thus both the IUL haptics are tucked into the pre-placed tunnels, and the IUL is well centered, and the wounds well hydrated, and the little anterior bag vitrectomy is underway now. The anterior vitrectomy is performed, and people is down, the wound is hydrated, and it is well centered. To conclude, the slow motion factor surgery for cataract with zonular weakness is a recommended procedure. Some procedures require patient precision and pre-planning. The slow motion technique enhances safety and shows better outcome for challenging cases like this one. And again, the message is and progressive nature of subluxations, one should not leave it as such even if it is well-centered, but fixate or cut the IOL habits. Thank you very much for your attention.
So this is the summary, and we don't go through it. Just control fluidics, decrease the bottle height, and decrease the phaco energy, decrease the vacuum, and be patient. The second instrument needs to be relatively more active, and chop it in multiple wedges, and be careful throughout the procedure that we need to be cautious of the zonular weakness where it is, and we don't need to aggravate it. Another point in rexes is start the rexes from attached zonules towards detached zonules. The initial incision for rexes is from attached zonules towards detached zonules so that there is no stress on the already weakened zonules. So, if you are well prepared and you have the necessary gadgets and patience, you can give excellent results in such cases. Thank you very much for your attention.
Thank you, Professor Mazari, for two consecutive presentations of high level and good audience. If there is any question or comment, there is a short one question can be asked. Okay. Dr. Ahmed Jaz, young ophthalmologist, son of our great ophthalmologist, Dr. Ejaz is on board here on DICE, and he will talk on comparison of visual outcome in trifocal and EDOF IOL in terms of patient satisfaction level and vision related quality of life. Dr. Ahmed Ejaz.
Assalamu alaikum. I'm Dr. Ahmed Ijaz, and I'm going to present this research which was done to evaluate the differences between patients implanted with either an EDOF IOL or a trifocal IOL. First, let's look at their mechanisms. The EDOF lenses have an outer portion for far vision, just like a monofocal lens, and they also have a portion dedicated to near to intermediate vision, which works by creating this what they call pseudo non-refractive beam, which extends its depth of focus, hence the name. Now keep in mind that not all EDOF lenses are created the same, and there are some differences between different manufacturers. Trifocal lenses, on the other hand, are essentially a Fresnel lens on which we have these diffractive rings, and the light that hits these diffractive rings is diffracted, and it produces these interference patterns, and where the light constructively interferes are essentially the focal points of the lens. Now let's look at the methodology. This research was conducted in Site Center Hospital, Bahawalpur, and all the surgeries were performed by a single surgeon to reduce any bias that could have come if surgeries were performed by surgeons of different skill levels. And that surgeon was Dr. Ijaz Latif, who is also here with us today. A total number of 120 subjects were selected for this study, 60 of which had trifocal IOLs implanted in both of their eyes, and the rest 60 had EDOF in both of their eyes. The subjects selected for this study, they were all leading a healthy and active life, didn't have any comorbidities and or any ocular pathology. So patients with diabetic retinopathy or retinitis pigmentosa, corneal opacity, or any other ocular pathology were not selected for this study. The data was collected on a tailor-made pro forma, which had 3 sections. The first section was about the demographic data, which the age, gender, and the education status of the patient. The second section was about vision-related quality of life for near, intermediate, and far vision, each having further 3 criteria. More on that in a second. And the third section was about patient satisfaction level, which had yes or no as answers. The data was collected and analyzed with Mann-Whitney U test, with help of SPSS software. And here are the results. So vision related quality of life for near, intermediate and far vision. As you can see, for near vision, trifocals are clearly better. A higher number means better here. So a significant difference was found between putting threads into a needle and using mobile phone at p-value of less than 0.05 as indicated by those highlighted boxes. So for near vision, trifocals are clearly better, and that's also the reason why patients with trifocals were much more likely to get spectacle independence, meaning that they didn't have to wear glasses for near work. For intermediate vision, they performed almost equally. Trifocals performed better while cooking and using computer, whereas the EDOFs performed better uh, while seeing speedometer. So for intermediate, it's a tie. For far vision, they both are good, but EDOFs have an edge. They scored better while reading a score of a cricket match and seeing the time on a wall clock. And the patients with EDOF also experienced much less scattering of light. And that's where the main disadvantage of trifocals come in, which is that patients with trifocals experience much more nighttime dysphotopsias, like glares, halos, and streaks. And that's why they're not recommended to people who need to drive frequently at night, such as truck drivers who can't afford to have these issues. The last section was about patient satisfaction level. Here also things are very equal. You can see that patients were equally satisfied with the improved vision they got after surgery at 30 each. And patients were slightly more satisfied with the improved quality of life they got after surgery and whether the surgery met their expectations or not. But the differences are very minimal. So in conclusion, EDOFs are very good for far vision, intermediate vision, but not as good for the near vision. Whereas trifocals are good everywhere except that they produce much more halos and glares. And ultimately, the lens that's going to perform better would be the one which is going to be more suitable for patients' individual lifestyle and requirements. And with that, I will conclude. If you guys have any questions, please ask away.
Thank you, Dr. Ahmed. Now I will request our most honorable senior ophthalmologist, one of the legends, Professor Major General Madhur Ishaq. He will have talk on flax with premium IOL, a complete solution. हर चीज़ का हल इसी में है.
Bismillah, thank you organizers for letting me speak on this topic. Basically, in the end I put a question mark also. In ophthalmology or in any science, there's nothing complete. It's just whenever you talk about something, something new is going to come up. But I'm just going to give you a brief resume that where do we stand and what are we up to at the moment. We just know that FLAG stands for femto laser cataract surgery, and it started in 2001. 2009 it was really put up, and it is only in 2010 that we have the FDA was approved this thing to be like this. The first machine which I started was in Lensic. This is a Elcon machine which we started doing it in AFIO. It's I think so. Basically, just to give you a bit of thing, it's has got an interface which goes into the machine. Then we put it on the eye, and everybody thinks that it's going to be painful. It's not at all painful. And then we do the whole trick. I'm just, because paucity of time, I'm not going to go into detail of the steps. Then I started on a Zimmer machine. This is also a flax which does it, and then the latest one is the Zimmer Z8. So these are all machines which are used for femtocataract surgery. Without going to dwelling into the detail I will just go into the pros and cons at what these are. That what has been scientifically been proven, that I'm going to talk about, that cataract in CN artery is more precise in flax as compared to a normal, and there are less chances of leakage, and improves chamber stability, and HOAs are also less induced. This is what has been proven till now. And we all know that the best part of it is the capsule rhexis, which is very round, and it can lead to good centration of the eye. And moreover, because it causes breakage into 4 pieces, it's good enough to that the energy in the phaco is also used less. The safety profile has also been checked, and in all the studies it has shown that the processes is much safer. But it doesn't mean that it is possible in all eyes. Still, it causes the selection of patient is important. If it's a small interpupillary distance, if it is a small eye, or if the pupil is very small, it is kind of a contraindicated. So these are the few things which are a problem. Also, if the patient is uncooperative, you can't do it. Then, if you think so, it is something very automated that you shuru kare and then you are just going to be a master of it. No, it has got a learning curve. And let me tell you, when I started off doing it, I thought my phaco has gone bad. So these are the pros. It is not something which is very simple, because you have to change your style of doing a surgery. So that is also very important. And you have to understand all the process. And even I&A becomes a bit more difficult, and there's a more technique is different from what you normally do in figure. So these are things. Rest of the other small complications which I'm not going to do it. And just to give you another picture of it, that all of these things are fine, but the most important aspect, whatever we talk about, is the economy. Is it cost effective? No, it is not at all cost effective. So I'm not going to dwell on this thing that it is not, but it is still, it's part and parcel of something which is going on all over the world. So I thought I'm going to care about it. And we are in Pakistan also doing it. And we have started having, it is common in some private sector also, and now it is also going into the, in some public sectors also, like in army also, and also in Shifa Trust Hospital in Pindi. So, but what the aim is after this kind of surgery is with doing a premium IOL, what are the benefits of this thing? So after talking all of these things, I think so we all know that what are the premium IOLs do, which we have already done. But I think so the most transparent aspect of whatever we do, whatever method we do, it is the pre-op assessment. And since it is a whole topic, so I'm not going to dwell much on this thing, but just going to go that we have to have a proper pre-op assessment, and before that we can't. And the surgeons, again, as the previous speaker has said, it is what is the most appropriate IL for the patient, and for that you have to have a plan, and that is very important aspect which needs a complete discussion on it, and that should be your surgical plan. And as we have already discussed, that there are a lot of types of IOLs, and we know that each have got its pros and cons about these things. But the important thing as far as flax is concerned, what does it do? The femtocataract surgery has that ability that if you have got an astigmatism, that can be corrected automatically. And just time to go through it, we know that any kind of astigmatism can be done manually, or it can be done surgically. So we know that if it is a mild astigmatism, less than 1, it can be done by the different methods which we know, and because this is not a lecture on astigmatism, but we can do it on cell. But we remember that there's more than 30% of cases are astigmatism. So you have to think about 2 aspects: whether to do them, correct them by the machine, or you do it by a toric IOL. But what I do in my practice, that if it is somebody is between more than 0.5 and between 1.5, I do it on my flax. So that is the benefit. So the cost is not of the toric lens is reduced. So that is how we do. So this is the configuration, and you can just make out that these are the marks in which we do. I'm going to show a video how we do it. So you can assess it, and you can, on the OCT, you can do this thing. So I'll just show you the procedure itself. That I'm just going to go a bit forward because this is a normal cataract. So so basically, it's not moving. So in any case of what is the important thing is that you can remove the capsule excess, and what is that other aspect of this thing is that correction of astigmatism by can also be done by the premium IOLs like toric IOLs, and we know either you do a manual technique or you can do by a Varion, which is another image guided system which is also available with it, which is not a part of the machine, but it is but be done. And for that, I can show you a whole aspect of this thing, that even a case if you are planning to do a panoptic or a toric or a multifocal IOL, and if you do not correct its astigmatism, the patient is not going to be happy. So the benefit of having correcting astigmatism is very important, and that can be done by flax, by doing a LRI, or we can do by using panoptic toric IOLs, and that can be all this with along with this thing. The important aspects of all the premium IOLs is that it has to have all the aspects have to be very important. It has to be a patient selection, the counseling, accurate biometry, a refractive target, centering the capsule axis, OVD to be taken out from the toric as from behind the lens, and you have to accept this thing. I will dwell on only one point. Should training be part of laser refractive surgery be formalized? What I mean to say that should all of this treatment should be part of or part 2 training, and that is being I've got a very aspect of this thing. I think so. We have to dwell on this thing, and for that we have already started off a cataract and refractive second fellowship in College of Physician and Surgeon, which I think so. My colleagues, the chairs are sitting over here, and I think so. We are in this direction, going in this direction that we need to improve upon. This is a very important aspect of. It is not only nowadays just the cataract surgery. It is important that the patient should be glasses free, and therefore formal training would best prepare residents and fellows to become safe, competent refractive surgeons. It's not a very cost effective procedure. We are making a second fellowship in CPSP, and we are making its guideline, and OSP is already working on this thing along with CPSP to form a committee and working on this for a second fellowship in this subject. So with this, I think so the technology is there for us. It make our life easy, and more importantly, it can make our patient happier. And let's go for that. Thank you very much. And the take-home message is technology is there for us. Thank you.
Thank you very much, sir. Technology and the experts using the technology, that is also important. The man behind the gun. Thank you. And now I will request the chairperson of today's session, Dr. Sufia, Principal QMC, to have her talk on aid of a step forward in the cataract surgery.
So we've been talking about EDOF a lot, and we'll be continuing in that vein a bit more. First of all, we need to understand that all of us are basically using, 90% of the times we are using monofocal IOLs. And the drawback of monofocal IOLs are that they give you excellent distance vision, but the intermediate and the near vision is lost, and the patient has to wear glasses for it. So at the end of the day, you still have spectacles, but distance vision isn't. The good part is that they are less expensive and easily affordable. Now comes the second part, which are extended monofocal IOLs. The new extended monofocal IOLs are basically IOLs that are monofocal, which means that they don't have that central disc. And they are not basically multifocal, in which you have all the modalities for the far, intermediate, as well as distant vision. But these monofocal IOLs are safe because they give you a good functional intermediate vision. What do you want from a monofocal IOL with an extended vision or extended depth of focus? You want the same distance visual acuity as a monofocal IOL. You want a bit more of the intermediate visual acuity. You want less dysphotopsias and a good contrast sensitivity and a less surgical time. We all know that the visual needs of patients my age, that's more than above 50, our activities have changed a little bit. We're more social, we like to watch more TV, we like to use our mobiles more often, we are using computers a lot, traveling, social gatherings. And during all these activities, intermediate vision plays an important role. And when you look at your daily task, while you are driving and you can't look at the dashboard, for example, the other day, I was driving and using my mobile, and suddenly the camera mode shifted, and I was surprised. I said, "Why has the camera mode of my car visual screen changed?" And it was giving me a kind of a warning and saying that you should pay attention to your surrounding environment. And it was a great difficulty. Yeah, a good car. Chinese cars, they are the limit. You may give me suggestions like a chatbot that you should pay more attention to your surrounding environment, and right now you're on TV. So, like things like these, as things have changed, these are things which are happening to us, all of us in our daily lives, and which is why we actually need a lens with an extended depth of focus, which can give you a good visual acuity and also a good intermediate visual acuity. What do you mean by the extension? So the picture at the top shows you a narrow depth of field, or a normal one, and the bottom picture will give you a depth of field which is a line focus, and it has an extended field of vision. So these extended depth of focus lenses are preloaded, and of course they have the modified wavefront technology. Professor Moeen explained it quite well just earlier, so we won't focus on that. These are a combination of defocus and positive and negative spherical aberrations. Professor Sahab, he talked about aberrations. Now, aberrations play a very important role in dysphotopsias, and we should always remember that spherical aberrations are the basic cause for all those aberrations or the visual disturbances that you are seeing. Now, what happens when you are using a wavefront technology, or you are using an extended depth of focus lens? Number one, the spider web light, which is caused by the cuneiform structure, and the halos and the starbursts are lost. You don't see that anymore. You see that a lot. These spider web lights and these halos and starbursts are more common with those lenses which have multifocal or trifocal technology. What do you want to use, or what do you want to have? You want to have an extension and a continuity of focus and able to see that intermediate vision, and you want to avoid the side effects of night vision, that is the halos and the glare of light. While driving, the oncoming lights of the cars can, they create a lot of disturbances, particularly when you are using multifocal IOLs. So we have an extended depth of focus in monofocal IOLs. Please keep in mind that we are not now talking about monofocal IOLs which have just an extended depth of focus. These are not multifocal, these are not trifocals, these are monofocal. They give you a good visual acuity for distance, they give you a good intermediate vision, they give you functional near vision, but if the patient really wants to read something which is of a smaller print, then you have to tell them they will have to use spectacles. The trick to using these type of extended depth of focal lenses is counseling, in my opinion. If you counsel your patient beforehand, that you will be able to see good for distance, you will be able to see a computer screen well enough, and you will be able to read large print. For example, you will be able to read Quran and stuff like that. But be very clear in your counseling that you won't be able to read small print. If you don't make that clear to the patient, of course, he will be an dissatisfied patient. You don't want that. These are these like monofocal light, they have the same photopic and mesopic conditions. They work in the same case, and there is a greater tolerance to the residual refractive errors, which is tilt and decentration. When you are using multifocal lenses, tilt and decentration play a major role in the side effects when you use these IOLs. But with these monofocal lenses, even if your surgical technique is not, like perfect, even then they would function pretty well. The performance and quality can be measured through that modulation transfer function, which has been explained. This clinical performance was well explained by Dr. Ahmed Ejaz, our young upcoming resident. Welcome to the club, Ahmed. And at the end of my talk, I would like to just conclude by saying that these innovative optical designs are based on optimization of the spherical aberration technology. Extended aspheric monofocal non-diffractive platform creates a single elongated focal point in order to enhance the depth of focus. There is a match between the aberrometric design and the IOL design. There is a comparable distance vision to a standard aspherical monofocal IOL, but you have the advantage of extended depth of focus in order to improve the intermediate vision up to 6 centimeter. There is no loss in contrast sensitivity. Aberrometric data close to the natural vision of the human eye, and there is no photopic phenomena, and there is a higher tolerance to residual refractive errors. Take-home messages: if you are using a monofocal DOF IOL, you have an add power of plus 1.75 diopters, distance and intermediate vision. Somewhat reading glasses like plus 1.25 diopters may be required for smaller prints. It facilitates in your daily tasks, and you don't really have to use glasses all the times. Very helpful if you're using computers, which we all do right now nowadays. If you're playing games, you are cooking, I don't know, social gatherings, and even climbing stairs, like that makes a difference while you're doing that. And as I mentioned, my own personal experience while you're watching the dashboard and driving. And all these would not be given by the monofocal IOLs. So as far as this technology is concerned, use the added advantage of intermediate vision, and cost effectiveness is the take-home message right here. Thank you very much.
Assalamu alaikum, and a very happy good morning on a very good and cold morning of the city Lahore. Last year it was not that cold. Dr. Sufi had presented a very good case with good detail, and it's a sort of latest technology even in advancements in EDOF lenses. Things always keep on improving, and we lag behind. When trifocals came in vogue and bifocals earlier, I thought that we have reached some sort of our future remains, and we are very happy that we are providing people with vision for all distances, but diffractions and halos and fidus photopsias were there. So we used to counsel them that these things are there if you have to go for these lenses. Then EDOF lenses were introduced. Initially, there was a sort of problem that is always there when there is a new thing in the market, that they are not that comparable. That is, if somebody has to use some glasses for near, why not to go for monofocal with no dysphotopsia? However, it improved in quality as well as in depth of focus, and near vein problem is sorted to some extent as well. Dysphotopsia has reduced. So I will not go into much details. The things have been discussed in detail earlier. So these types of trifocals were used, trifocal, EDOF, accommodative are still a technology developing, and if it develops, it will add a lot because it will be controlled by the person without any aberrations or things. But still it is a futuristic approach. This is a vision our patient like to see after surgery. and this is the daylight vision, and this is the vision at dusk and dawn. That is a requirement. So these are various lenses. I will not go into details of the different. This EDOF technology discussed already how these trifocals and then EDOF they work. These were the trifocal type, very good lenses indeed. Still they are very good, and for some people this is the best as compared to EDOF lenses, particularly these trifocal lenses. These are good companies with good lenses. All are. Now, as discussed with, by Professor Mazari, Professor Moin, and my other colleagues, technology changed when EDOF came into practice. What is it? Very brief, there is single monofocal beam that passes all across the optical media as a pseudo non-diffracting beam and directly lands at the macula with a line focus. It corrects all the aberrations for distances and makes a sharp image here. But the problem is that the field of vision in that area is very, very minimized by the single beam. So it was good to introduce this center zone that is basically subject for this all this pseudo non-diffracting beam. And this I did a lot of this lens implants. Things were good, patients were good for distance intermediate, but almost all the patients they needed plus 1.5 or plus 1.25 reading glasses. So the patient used to compare it with trifocal that they don't need glasses. So here was the problem. So with the passage of time, the new lenses came with the better technology with having two zones, surface transition zone 1 and 2. Zone 1 is the central 1 millimeter zone, slightly elevated, and that actually forms the single pseudo non-diffracting beam as discussed. And the second zone is this outer zone that is 2.2 millimeter. विविडी में भी होता है और जाइस वालों में भी होता है और बाकी जो लेटेस्ट आ रहे हैं उन सब में ये जोन है. ये क्या करता है, ये इस सिंगल बीम को it takes the light source from the outer parts of the field and makes it in continuity with the single beam as it passes through the media. Now, once this beam is passing through the media and reaching the macula, it does not have only the single central beam part, but lot of field, which not only increases the field of vision and depth of focus, it also increases the quality of vision in low light. For example, mesopic conditions. कैसे? Because it takes more light from the field with more light energy. So if you go from the daylight or bright light to darker light, there's no jump that with other monofocal, with other these EDOF lenses is seen, or even trifocals. इसमें वो फील्ड भी अच्छा रहता है, इसमें लाइट भी अच्छी होती है, लाइट एनर्जी, तो इसका बेहतर इमेज बनता है. तो पेशेंट्स यूजिंग दिस टेक्नोलॉजी, विबिडी में बहुत सारे लेंस है इनका, Evolux में भी है. So they give very good performance. Now can I ask a question from my friends who have been using multifocal, trifocals as well as EDOF? How they compare the feedback from the patients about trifocality and loss, without dysphotopsia. मजीद साहब होंगे, मोइन साहब होंगे, जनरल चले गए, एजाज लतीफ़ जिनको मैं जानता हूँ, बाकी बहुत लोग हैं माशाल्लाह. So, madam, can I have Dr. Bilal sahab, can have you comment on this thing? What is the latest feedback from the patients?
Is it on?
Please.
I'm sorry, I do very limited cataract surgeries, so my actually input will not be valid. I'm a vitreoretinal surgeon, and in USA it's considered like a.
Thank you very much.
Yeah.
Ejaz? Mic देना पड़ता है. Because it is a very sensitive topic, and still we have to have a lot of education of the patient.
Assalamu alaikum and good morning, ladies and gentlemen. I have a vast experience of using all three lenses, multifocal first and then trifocal and EDOF. And to my experience, the best satisfied people are with trifocal at the moment, although they have some distortion of the lights, especially when traveling onwards on a high speed. But I tell them that they will find this problem. So suppose the light is 6 inches and you find it 1 foot. It doesn't matter for you, but you will see very clearly the road. Even the single stone on the road can be seen very clearly, because I have got the personal experience of this. I have got trifocal IOLs in my own eyes, and I am doing all sort of surgery with the very much comfortable, and I drive very fast, and people know I can drive more than 200 kilometers per hour. And I usually drive this. 220 is my normal speed sometimes.
You are always fast everywhere.
But no, अब FIR होती तो मैंने छोड़ दी है ना. तो मैं ये बताना चाहता हूँ कि at every distance you see very clearly, and with these trifocal IOLs, and at every distance I can read very thin or small letters on the mobile. So trifocal, in my opinion, are the best at this moment.
Thank you.
Yeah, glare is not that much. No, it doesn't matter. It's not that much glare. You can drive in the evening, at the night. You can drive. I am driving at any time and long drives, but honestly, I never feel a problem in a single time. सिर्फ आपने, you have to counsel them before surgery that you will have this slight problem, but why should we look into the light? Until we look into the light, we don't feel any problem. I don't feel any problem.
Sir,
So
thank you.
I was.
Thank you very much.
Sir, I would just like to add one thing, that for the audience, it's not the trifocal that is driving at 200 kilometers. It's like Professor Ijaz Saab, who's driving at 200 at the speed of 200 kilometers per hour. Wouldn't advise it. People are being put behind the bars for that. Sir, please continue with your presentation, Majid sir. Sir, thank you. Sir, thank you, Ijaz Saab, sir. Thank you for your comment.
आगे नहीं चल रही. आगे नहीं.
सर नहीं चल रही तो फिर बेल मनी
चलिए
का
बात करते हैं. चलिए. The important thing is not that which lens is being used, it is the counseling and the requirement of the patient. आज का ज़माना बदल गया है, लोगों की ज़्यादा कंप्यूटर विजन, स्क्रीन टाइम बहुत ज़्यादा है लोगों के. उन लोगों के लिए जो मैंने एक्सपीरियंस किया अपना लेटेस्ट, the people who are using this good quality, latest quality EDOF, what I do, I add power of plus 0.5 to one lens of the two eyes. So it is a bit myope in one eye, and that gives further depth for near vision. So these people with slight myopic shift in one eye, they are better patients to tolerate, and they are actually more comfortable for their work. लेकिन एक बंदा है फील्ड में काम करना है, आउटडोर में रहना है. There is a lady जिसने आउटडोर में ही काम करना है, जिसने अपना कोई काम नहीं है, शाम को ड्राइविंग पे जाना है, अपने फैमिली के साथ जाना है, she goes to market. It is better for her to have trifocal lenses because that gives better quality of vision for all distances. So जहाँ diffractive photopsia का प्रॉब्लम हो जाए वहाँ पे आप चेंज कर दें. Thank you very much for the discussion. बहुत शुक्रिया.
We have another speaker, Dr. Mohammad Awais Asghar Saab.
Awais Asghar here.
Awais Asghar Saab has two talks, conquering the gentle, safe and conquering the granite, safe and effective approach for cataract and Niagara, and another one on posterior polar cataract. मुझे पता था वहाँ याद नहीं रहे.
Assalamu alaikum. I'm Dr. Awais. I am going to present basically the posterior polar cataracts. We are back to the basics. You must do a good cataract surgery for these alloys that have already been discussed. So first of all, posterior polar cataract is a opacity involving the posterior capsule, and it's quite adherent to it. And the posterior capsule is quite weak in these cases. In routine cases, it is around 5 to 10 micrometers, but in cases with posterior polar cataracts, it is around 2 to 4 micrometers. PCR rate is around 26 to 36%, and it can be reduced to 7 to 11%, but in some cases, in good expert hands, it can drop to less than 5% even. So what are the essentials for the preoperative assessment? You must do a slit lamp examination to rule out that is there any primary PCR or not. Fish egg formation or fish tail formation behind the posterior capsule is a basic sign of primary PCR. Anterior segmentosity, if available, can be a good helping hand. Secondly, we must classify these posterior polar cataracts. Type 1 and type 2 are basically posterior polar cataracts with onion ring appearance or a disc at the posterior pole, and they have a moderate risk for PCR rupture. Type 3 are those cataracts with white spots at the edge of the opacity and fishtail formation. And type 4 are those with type 1 and type 2 with nuclear sclerosis grade 3 and grade 4. They have mixed risks. Depending on the surgeon competency, there can be problems with it or not. So I'm going to present assortment of cases. This is the first case. Here you can see that nugget is present at the posterior capsule. First, I'm giving corneal incisions and next we will do a rexis. An appropriate rexis of 5.5 millimeter size is important. A smaller rexis will have problems with nuclear delivery, removal of the nucleus, and irrigation and removal of the epinucleus. Here I have done hydrodelineation. I have not done hydrodissection. After hydrodelineation, I am going to divide I'm removing the epinucleus currently and going to chop the nucleus in the center, removing the both halves easily. My aspiration flow rate is 50, vacuum is 550, and power is 60. I know that people do concern that slower fluidics must be adopted here, but once you get used to it using the high vacuums, you can easily manipulate such cases at these settings. After removing the nucleus, I haven't done viscodissection. I am doing manual dissection with phaco pedal. My anterior chamber hasn't even collapsed for a single time, and I have done all the phaco in the way. After removing the capsule, you need to address the epinucleus. After removing the epinucleus, you get to implanting the IOL in the back. I usually do that with hydroimplantation. Next case. This is a case with a nuclear sclerosis 3 with a posterior polar cataract and moderately dilated pupil. Here again we are going to give corneal incisions as before and a touch of silicone with a drilling dilate the pupil. Chop into two. Do not rotate the nucleus. Initiate the remaining chopping while holding the remaining half nuclei. The chop hasn't initiated. I have hold the nucleus at another point. Chopped it again. Move the piece. half of the nucleus, you can easily dial the remaining half, because hydrogen dissection will automatically occur to phaco's fluid. This is also the settings that the same method. I have done all the phaco. Moving to the next case, this is another case of a posterior polar cataract with NS3. Here the nucleus didn't move with the hydrodissection of the phaco's fluidics. Again, showing you all the steps. Here there was a slight extension of the rexis that I had to rescue. No hydrodissection or hydrodissection, dropping the nucleus to the phaco and removing the pieces then and there without any rotation. Holding the pieces without rotation is of utmost importance in such cases. I will demonstrate the maneuver if the nucleus remaining nucleus doesn't move. I'm going to hold it with phaco and rotate it with phaco. Doing all the phaco in the bag.
थैंक यू डॉक्टर सर, टाइम हो गया आप काफ़ी.
Sir, बस दो मिनट दे दें. So the golden rules for the surgery are no hydrodissection, hydrodelineation only in the soft cataracts. In harder cataracts, it can lead to hydrodissection. And CN and rexis must be appropriate size, 5.5 millimeter, and the golden ring only in the softer cataracts. Madam, I am using Otley here. Otley Sparrows. Yes, peristaltic pump. No, not a Venturi pump. If you don't get, you are not used to do a manual dissection, then you can do a visco dissection here also, and you must be ready to manage PCR at all times with all the instruments available. You must be having a VR setup also if the nucleus drops in such cases, but with expertise and with practice, you can reduce the PCR rate to less than 5%. And if the rent occurs, it usually occurs at the last point or at the first point on the first crack. If there is a crack in the first point, doing hydrodelineation or hydrodissection will free the nucleus and the nucleus will drop. And if you haven't done that, the nucleus won't drop, it will easily phaco out. Thank you.
Thank you very much, Dr. AdvancedCataract. Very good surgery and very good videos. Now, anybody with any question or comment on any presentation? आपके दोस्त आ गए. Any को गाते प्रयास किए.
It was a hello. You can listen to me. It was a beautiful presentation, and one thing I just want to add, because of my personal experience, I have got so many presentations on this posterior capsule, posterior polar cataract. But there's one important thing that most of the time when you remove this cataract, and there is this slightly powder-like substance which is right in the center of the area, and don't try to polish the center of the posterior capsule in such cases of the posterior pole. Just first of all, after removing the cortex, and place your IOL in the bag, and then try if you want to try. Otherwise, you can do it with the jag. Most of the time, this is so delicate that even touching with the cannula will cause a rupture of this. And I have got this experience many times that after completing the surgery beautifully, I just try to polish the capsule, and just I touched and it ruptured. So मेरा ये ख्वाहिश है कि यानी एडवाइस है पर्सनल बहुत एक्सपीरियंस के बाद कि आप इसको कैप्सूल पॉलिशिंग की बहुत आपको टेम्पटेशन होती है कि यार इसको पॉलिश कर लें, लेकिन कोशिश ना करें, उसको टच ना करें बिल्कुल। और अनएक्सपेक्टेडली यू टच तो अनएक्सपेक्टेडली फ़ौरन ये रप्चर कर जाता है समटाइम्स, तो इसको अवॉइड करने के लिए ये भी एक स्टेप आप याद रखें। थैंक यू सो मच।
Hello. Yeah, I want to add some points for multifocal and EDOF experience. Like in multifocal, the first important thing is to check like dominant and non-dominant eye and stereopsis. You should also always check if the patient has stereopsis or not. If the patient is amblyopic and you put multifocal IOL, that is not going to work. In those patients, EDOF are the better. And then what I am using in Manchester, I am doing mix and match. Like I use EDOF IOL is a pure C IOL is a new IOL in this field, which is a monofocal EDOF IOL. That IOL I use in dominant eye to prevent glare and halos, and in non-dominant eye I'm using the multifocal, so that when the patient is driving at night time, the dominant eye overtakes and the patient doesn't get any halos or glare. And when he is reading or doing near work, the multifocal lens is working very well for near. So before I was using Synergy by Johnson & Johnson, because Pure C is also by Johnson & Johnson. But now there is a new lens, Odyssey. So I am using mix and match combination, like in dominant eye Pure C.
Good idea. Good idea.
And in non-dominant, the Odyssey. So this combination is working very well.
So it is better feedback from the patients?
Sorry?
Better feedback, patient?
Yeah, 100%.
Good.
Like I use on many doctor colleagues, their consultant and many other
Excellent.
friends as well, and got a very good feedback. They don't have any complaint of glare and halos.
Thank you very much.
Thank you.
I am so grateful to all the presenters and audience, especially who came in the morning. It is difficult. Traffic was fairly high on the roads. So thank you very much. We will have a picture of all the speakers. Moin sahab, aap bhi aa jaएं. All the speakers, please, to have a picture here.